if there's going to be an LDL related risk, it has something to do with how high for how long. And in the absence of having a lot to begin with, I'm hard pressed to say that every person with a high LDL is equally at risk. Just taking the LDL at face value, you'd like to know how bad and for how long.
A physician and lipid expert with over 30 years of experience in lipidology is now doing something he would have thought was absolutely crazy 20 years ago. He is encouraging the study and exploration of individuals who are lean mass hyperresponders with LDLs above 200, 300, and what this might mean for their health and what it might mean for them following a ketogenic diet. So let's hear his incredibly reasonable, but unfortunately uncommon approach. Welcome back to Metabolic Mind. I'm Dr. Bret Scher. Metabolic Mind is a nonprofit initiative Bazooki Group where we're transforming the study and treatment of mental disorders by exploring the connection between metabolism and brain health. Today I'm joined by Dr. William Cromwell of the Lipoprotein and Metabolic Disorders Institute, who's also the Chief Medical Officer of Precision Health Reports and the Principal Investigator and Medical Director of Velocity Clinical Research. He's involved in the clinical side of things and the research side of things to explore about lipids, all about lipids. And we're going to tie in what this means for people following a ketogenic diet or therapeutic ketosis for other reasons who may have elevations in their LDL, and how do we tie this back to first principles? What does it mean for the individual? But before we get started, please remember our channel is for informational purposes only. We're not establishing a provider-patient relationship, and we're not giving individual or group healthcare advice. Many of the things we talk about can be dangerous if done without proper clinical supervision, so always consult your healthcare team before making any decisions regarding your individual health. All right, so with that, let's get on with the interview with Dr. William Cromwell. Well, Dr. Cromwell, thank you so much for joining me today at Metabolic Mind.
Oh, my pleasure. Thank you.
Well, as we heard in the introduction, you have a number of different hats you wear, a number of different roles, from the clinical side to the research side to the sort of individualization and precision medicine, so to speak, of how do we create a better plan for an individual rather than a population. So with that as sort of like a general context, tell me about your overall approach in medicine of how we have these guidelines geared towards everybody, sort of to make practice easier on a clinician, but maybe how that sits uneasy with you in thinking about how we need to personalize things for individuals. Tell us about that, push and pull with you in your practice.
That's a great question because, the evolution of guidelines has been what I call least common denominator medicine. We start with the idea there's a problem, let's say heart disease. And there are big levers that have been identified called major risk factors. And so early on, we thought the more of these you have, the worse you are as far as your risk of heart attack and stroke. And it wasn't very personalized. It was just putting people in buckets. And these buckets were sometimes informed by equations. And you would take an equation that linked certain pieces of information in some kind of weighted fashion. And you come up with an idea of who's more at risk, who's less at risk. And those who are more at risk get more stuff, and people who are less at risk, less stuff. That was medicine for a long time. And as you know, and our listeners as well, within a group, there's a lot of difference. There's a lot of heterogeneity. So let's just say you happen to find yourself in a high-risk group. Is everybody similar in their risk? No. So what are we missing? We're missing a lot. And that was the approach to major diseases for a long time. And I guess in the heart disease realm, it was very reassuring to see in 2013 that the guidelines took a step back. And they said, there's more to this than just your cholesterol. There's more to this than just your blood pressure. There are things called risk-enhancing factors, and there's a bunch of them, over 30 of them. And they range, for example, from ladies who have had menopause below the age of 40, preeclampsia during pregnancy, inflammatory conditions like rheumatoid arthritis, psoriatic arthritis, chronic kidney disease, metabolic syndrome, a whole list of things. And none of that appears anywhere in the old calculations. Well, what do we do with that? So the guidelines said, well, you have to start somewhere. Start with major risk factors, start with these risk calculations, but don't stop there. Think broadly about the person. What else is going on? What about these risk-enhancing factors? What about whether they have blockage in their vessels already, as witnessed by some kind of imaging study? What if we know more than just their cholesterol? What about the particles that carry their cholesterol? What if we know these types of additional pieces of information? And so what the guidelines have done over the past 5 years is to speak to the fact that these are important parts of a physician-patient conversation. They don't tell you prescriptively how to do it. They tell you that these are important. And
Yeah.
so this is where a lot of my interest over the past 20 years has been, is how do I have a conversation that's a well-informed conversation, one patient at a time? And then if others wanted to have a well-informed conversation, how would they do that? Is there some sort of mechanism out there that people can tap into that would take the guideline recommended pieces of information and pull them together in such a way that you don't have to just be a name in a pot? You're in that high-risk pot. I actually know more about you. So this is an informed conversation. And perhaps we can identify some missing pieces of information like non-invasive imaging. Maybe that would be helpful.
Yeah.
And so that's what we did at Precision Health Reports, was to bring this together in a simple little platform where people answer some questions, get their blood work done, and then it gives them these detailed responses so they know how to have a conversation with their provider.
Yeah, I think that's a great sort of groundwork or framework of how we can learn more, we can understand more. Now, we can phrase it as learning more risk factors, but we can also phrase it as potentially identifying some protective factors or lack of risk factors. And I think that discussion is pretty critical for bringing it back to sort of what we at Metabolic Mind are, we're focusing on metabolic interventions and ketogenic interventions as treatment for brain-based disorders and for mental illness. But one of the biggest hangups is what happens to your LDL on a keto diet. And we know that there are some people where LDL goes up significantly. So bringing that into this framework of a discussion, well, do we need to know more about these individuals to say, could there be some protective factors that maybe that LDL doesn't mean as much, which is sort of like kicking a hornet's nest in cardiology and lipidology and medicine right now. So what are your initial thoughts on that concept of, could there be protective factors where elevated LDL and even markedly elevated LDL may not have the same implication that contemporary medicine thinks it does?
It's the right question, but it's a loaded question, as you said. So let me put a little more context around it. Is it the case that all high LDL is bad? No. Well, what are some nuances around that that would help us out? Well, one is chronicity. How long has it been high? Any major risk factor we think of as being problematic as how bad for how long. If you're talking about somebody who has historically been not so high, they've adopted a ketogenic diet for a good reason due to a medical condition they're trying to improve, and as one of the things that has happened, their LDL went up. Well, one way to look at that is the clock for whether that's bad or good just started. They weren't high before. They're high now. So is that instantly bad? No. It's like smoking. If people start smoking, is it instantly bad? Well, it's bad by how much and how long you smoke. So if there's going to be an LDL-related risk, it has something to do with how high for how long. And in the absence of having a lot to begin with, I'm hard-pressed to say that every person with a high LDL is equally at risk. Just taking the LDL at face value, you'd like to know how bad and for how long. So that's the first thing. The second thing is, you are right that any major risk factor works in a milieu, and it can be one where you're set up for success or not set up for success. And unfortunately, the types of people I see regularly are not metabolically healthy. These are folks with insulin resistance, metabolic syndrome, a cadre of things that together put them at risk. And some of that happens to be the particles that carry cholesterol, but that's not the entire story by any means. So we haven't spent a lot of time kicking the tires in the opposite direction. Would it be the case that people who are metabolically sound are a different cohort than people who are metabolically frail? And how does that metabolic frailty figure into the way our bodies are responding to LDL elevation, for example? And that's contentious. And people hear that and they say, now, wait a minute, LDL's bad. A lot of LDL's real bad. With caveats, that's generally true. But it's also the case that we know that there are situations where we can buffer or mitigate risk in a variety of ways. And so one of the things that we need to, I think, do a better job of researching and understanding is this idea that a ketogenic diet is producing a variety of effects, and that the metabolic circumstances of an individual who are manifesting an LDL elevation are fundamentally potentially different than others in whom we see high LDL that are kind of the one size fits all. We got to treat that. So I'm open to the idea that there can be a variety of reasons why elevated LDL can be more or less problematic in various states.
Yeah.
And I think at a baseline level, just understanding well who our patients are and then trying to put that LDL elevation in context is a better way to begin the conversation. So, for example, if somebody were 45 years old and they've got a condition for which a ketogenic diet is a reasonable expectation, and they adopt a ketogenic diet, they have a good response to whatever situation they're seeking to address. Unfortunately, their LDL went up. Well, in the context of our previous conversation, we would want to look more comprehensively. Right? Do we have risk-enhancing factors? Do we have evidence of blockage already? What else is going on? And if I have a metabolically healthy individual with no risk-enhancing factors, no evidence of any kind of plaque on a good non-invasive imaging study, that's a different conversation than somebody who, when they're worked up, wow, you have plaque already. What are we going to do about that in light of what is now a very high LDL? Is there a way that we can adjust the ketogenic diet in a way that doesn't have as much of a negative LDL impact, but still has the benefits of a ketogenic diet? A little tuning exercise, right?
Yeah.
I don't think we have to, look at this as it's an all or none phenomenology. And I don't think we have to look at this as if I need to do something about that, it's a pharmacotherapy or nothing.
Now, hearing you say that is just like, of course, it just makes so much sense. But yet, I think the average person listening to this is like, well, my doctor doesn't say that. Why can't I get my doctor to approach it that way? So why? Like, why do people struggle to find a doctor to think or to approach it just the way you just said?
Well, I have opinions. I'm not sure any of them are right. Yeah, I've spent a lot of time in this one space. I've spent 33 years in lipidology. So cholesterol metabolism, lipoprotein metabolism, vascular disease is what I have thought a lot about and done all my work in for, 3 decades. And at the end of that, I can tell you, I think differently now than I did 20 years ago. And that's a good thing. You learn, you grow, data inform you. And so I'm the benefit of having worked with a lot of great people, many of whom have some real cutting edge ideas, even contemporary cutting edge ideas. And it keeps you in an ever learning mode. I think that's one thing. I have the benefit of that others may not. I joke with people, I own a prostate, but I know nothing about it. So I'm not throwing stones at anybody. This has been an advantage that I've had. I think the second thing is we sometimes approach the exercise of medicine in different ways. I have not worked long periods of time in a healthcare system where I'm seeing people every 15 minutes.
Right.
If you're seeing somebody every 15 minutes and your task is to do something with their 3 or 4 active medical problems, good luck. And I think that is an impossible scenario to try to have this type of conversation in. And yet it seems to be where a lot of people find themselves. And so part of the solution is, we'll just layer more providers or extenders on this equation. So you'll see the doc and you'll see the nurse practitioner, and you'll see the PA, and you'll see the dietitian, and you'll see, and all of these pieces of the puzzle don't necessarily get integrated. There's nobody that's trying to shepherd this necessarily, right? They're just trying to limp through the day and get through the other side, and let's repeat tomorrow. That's an awful way to try to individualize care. So, and that's the second thing, is I think people find themselves in delivery systems that are not tuned for this exercise.
Yeah. Yeah, I think that makes a lot of sense. Now, so one of the things I really like to try and just shout from the rooftops is to encourage people to be their own advocate. And if they are in a system like that, to give them some tools to say, we can make this better for me, right? I'm not your guideline, I'm me. So we can make this better for me. So you mentioned non-invasive imaging studies. You said a good quality non-invasive imaging study to help define or better define the risk. So what are some of your go-tos for specifics that someone might be able to ask their doctor for?
Well, we can start with the low-hanging fruit. That's the coronary artery calcium score, also called a CAC score. It's a simple CT scan of the chest. It doesn't require any contrast. What it does is it looks for calcium in the arteries that feed the heart, the the coronary arteries. There shouldn't be calcium there, and calcium in those locations indicates the presence of a more mature calcified blockage. So the sensitivity of that test is not very high at a young age, but the specificity is very good. So if you've got a high number, we know what it means, but having a high number is something that happens over time. So let's say we go back to our 45-year-old example. If I'm a 45-year-old female and I have a 0 calcium score, I can still have blockage in my arteries. So a 0 in certain circumstances doesn't exclude disease, but a high number rules in disease. So it's a gate that swings one way in younger people. On the flip side, though, for an older cohort, say in their 70s or older, a 0 is magic. You look at people who have a 0 calcium score in their 70s, and their risk for heart attacks is much, much, much lower than others. Yeah. So it does have a little nuance to it, but it's so much easy to do. Every place that has a CT scan has the capability of doing it. It's a software package added to a CT scanner. And a lot of places, they'll sell it for about $99. February is Heart Month, and a lot of places, as an outreach to the community, offer it to people at their request. You just walk in and say, I want a calcium score. And so not a bad place to start, but understand that in certain populations, especially younger people, it's harder to be 100% confident that you've learned that your arteries are clean and just not identified as having calcification. So what's the next level up from that, right? So adding sensitivity to the equation would be what's called a CTA, a computed tomography angiogram. And what happens there is it's still a CT scan, still looking at the heart arteries, but they're using a contrast medium to get more information. It's more radiation. But at the same time, you can determine plaques that aren't calcified with this. And so now we've added the ability to find things that a CT or a coronary artery calcium score could miss. Just to give you an example, in some series of younger people in their early 40s with a 0 calcium score, about 1 in 5 actually have plaque identified on a CTA. And it's not an inconsequential number, 1 in 5. So we just have to understand now what are the limitations of that? As I said, it's a contrast study, a little more radiation, cost more. It would vary from place to place, but it could be $1,000, could be less. It's not going to be covered by almost any insurance. And so not a great screening tool, but might be in certain settings a good tool to get more specificity and more detail, right?
Yeah.
And then you start getting into things that are very operator dependent, like ultrasound. Ultrasound of certain arteries has been done for a long time. The neck arteries, the carotids, are well characterized and have been for decades. You know, they feed our brain. They're right here under the neck, under the skin. And so we can see them really well with ultrasound. One type of ultrasound is called a B as in boy mode ultrasound. And B mode is basically a wide transducer that gives you a picture of the wall of the artery from the top down. And what you're looking for are areas that are thick, that would be a plaque. So if you see focal thickness that's more than 1.5 millimeters, and you can see it in multiple different pictures and different angles, then that's a plaque. And now, I just told you that you're doing this transducer thing, right? So the technician is doing this, and they're going up and down and back and forth and what have you. So the quality of the scan has a lot to do with the person doing the study, how much time they take, how much they are interested in an area and get different pictures of it. It's not going to be the same one place to another. It's very operator dependent, but it's very sensitive. And you can find plaque much earlier than you would see it in certain cases in the coronary arteries. So all of these. And then the last thing, which is somewhat indirect, is looking for evidence of a plaque due to some change in blood flow. And we can do this also by ultrasound in the neck. It's called a Doppler study. You're looking at what's called flow velocity. And if you see that the number for flow velocity changes abruptly from one spot to another, you infer there to be a blockage there. That's indirect evidence. Another would be an ankle brachial index, which is not an imaging study at all. You're just taking a blood pressure in the arm and a blood pressure at the ankle, and you're doing a ratio. And if the ratio is less than 0.85, then you infer there to be a blockage. Again, not confirmatory, but just a screening tool. So these are all the different ways that people can think about trying to get an idea of whether they've got some kind of blockage or not.
Yeah, it's a very good overview of the numerous different tests, and also the catching things in different time frames, like the ankle brachial index or the velocity measuring of the arteries. Those are going to detect a narrowing that's already happened, so plaque that has really grown and is more advanced. Whereas the CT angiogram could really catch things at a very early stage. But unfortunately, that's also a harder test to get like a primary care doctor to order. They're not as comfortable with it. But that brings me to another discussion that we've had with Dave Feldman and Dr. Matt Budoff about their preliminary results for the study that they released, talking about the CT angiograms they did on people who are lean mass hyperresponders. So meaning they have LDL above 200, HDL above 80, triglycerides below 70 while following a ketogenic diet. And compared it to a similar age group control in the Miami Heart Study who did not have the high LDL, who are not on ketogenic diets. And basically, we have this whole interview, so I encourage people to go back and listen to that one. But the summary is that there was basically equivalent plaque scores between the groups, whether the LDL was 300, 400, 500, or 110, 120. Did not matter in the difference of the plaque score for this population. Now, I know you've talked to Dave about this and you've been interviewed before, but I'm curious, like when you hear results of a study like that, there's been a lot of talk about it from both sides of the equation. This is great. This tells us so much, or this is throwaway. It tells us nothing, right? Depending on which camp you're in. So how do you interpret this? How do you bring this into the perspective of taking care of the patient in front of you and what this means for the whole field?
So I think
that was a long question. Sorry about that.
I think there's a whole lot of nuance about this. There's a whole lot of ways that you set up the conversation to begin with. You're talking about 100 people. 100 people is not 100,000 people. So we don't have a huge N to begin with. That's number one. Number two, we have an abrupt change in LDL cholesterol after the adoption of a ketogenic low-carb diet in the individuals in this cohort. That doesn't necessarily tell me as much information as I would like about their cumulative exposure to LDL over time. We know it's gone up quite a bit, and the average was over 4 years. It had gone up quite a bit. Don't know what it was before. So if our model in part is how high for how long, the how long appears to be relatively short, 5 years or less. What happened before that, unclear to me. So then the question is, in that 5-year window, would we expect that to be a sufficient time frame to see a significant difference in 100 people versus 80 people and the characteristics that you just said? I don't know the answer to that. The fact that they were similar is good. I think that following them over time would be even better to get an idea of what the chronicity of exposure means in terms of any change in CTA, right? So I do think it's important data. We haven't looked at it before. So from the standpoint of what do we know about lean mass hyperresponders, well, there's a conversation unto itself, right? This is a combination, as you said, of high LDL, high triglyceride, low triglyceride in lean individuals on a ketogenic diet that have not been systematically well studied. We have emerging data, but it's not like we've been looking at these people for 3 or 4 decades and we have a large body of data to lead into. We have a small body of data, and we're still mechanistically working on the explanation of what's happening under the sheets in the first place with the Lipid Energy Model. So these are our early days. But I do take away from this a couple of things. Number one is these aren't just your run-of-the-mill high LDL patients. Let's just put that out there. That if you are otherwise metabolically healthy and lean and having a lean mass hyperresponder phenotype response to a ketogenic diet, we should not assume these people are like everybody else we've seen in the past with high LDL. They're different. Now, that could be different for the better. That could be different for the worse, but they're not the same, right? We just have to put that out there. The second thing is with the Lipid Energy Model, which I think is intriguing and one that I have warmed to, but I will tell you I was not necessarily on board early on in the conversation about a lipid energy model. It posits that when you're really lean and you're eating a high-fat, low-carb diet, that over time you become fat-adapted, fat for energy. And part of that is that you don't have a lot of carbohydrates stored. Your glycogen stores are low. You don't have a lot of stored stuff, right? Now, physiologically, what happens to people when that's you? Well, the lipid energy model would say what happens is you traffic energy differently. You're actually using free fatty acids to fuel your daily metabolism. And the way you're getting that is the liver is packaging triglyceride and VLDL particles and sending it out in a much higher quantity than previously expected. And when in the blood, it's acted upon by an enzyme, lipoprotein lipase, to liberate the fatty acids for you to burn for energy. Now, we've seen that happen in other contexts in the past. That part's not new. But the idea that it would happen at a high rate and a large magnitude is something that we're having to try on for size, because to really make sense, the lipid energy model would mean you'd have to pump out a lot of VLDL. And you would have to rapidly take the energy out of those particles to use for energy. And that would leave you with a large number of LDL particles, which is what you get when you break down VLDL, is these LDL particles. It would make lots and lots of LDL that you might be challenged to clear through the normal pathways. And that would be what the lipid energy model says would be an explanation for the high LDL. Now, that's not something you see elsewhere in medicine. That's not something, oh, yeah, I've seen that in diabetes. No, you haven't. Oh, I've seen that. No, you haven't. This is new.
No, you haven't.
Okay? So that's new. But, well, if that's true, what would you expect? Well, you would expect that the genesis of this, in part, is being carbohydrate depleted from certain tissue stores. So what happens if I refeed you with carbs? If I refeed you with carbs, could I basically let the body relax? We're good now. We don't have to pump out as much VLDL. And if that's what's driving the LDL up, maybe the LDL levels would somewhat normalize in a fairly rapid period of time, because I'm now supplanting or giving the body back what it needs. So this is the idea of the lipid energy model. And there are data out there to indicate that in a very short period of time, carbohydrate reintroduction can radically lower LDL levels consistent with the lipid energy model. And this is another new learning. And now, is it a complete model? Probably not. Are we going to continue to learn things? We will. Could there be LDL receptor things going on? Perhaps. But at the same time, I was intrigued, and have been for a few years, by Dave's work and others, as to how rapidly our physiology can adapt and adjust. And I really think of this as an adaptive lipoprotein change. That word makes, I think, some safe harbor for a lot of people. Is this, wrong? No. Is it broken? No. Is it dysregulated? No. It's adaptive. And you think about it, we get stuck on a desert island somewhere, we better adapt. We're in big trouble. If you're a hunter-gatherer and you caught your meal today and you don't have one tomorrow, I sure hope your body adapts. So physiologically, adaptation is not a foreign concept. It's just we're applying it to a cholesterol problem, high LDL, which is usually encountered for other reasons. And we're taking our previous understandings of high LDL and layering it on top of this and saying, well, from my existing knowledge, this should look like. And in point of fact, this could be an adaptive and different process, and fundamentally, mechanistically different, and perhaps with a different impact on such things as atherosclerosis as well.
Yeah, I really like how you phrase that. Adaptive, not broken, not wrong, adaptive, and for a reason, which we cannot then assume is going to play out exactly like everything we've seen before if we haven't seen it. So, but you did reference how adding back carbohydrates can rapidly lower the LDL and therefore affect this lipid energy model. So we just saw one example of that with Nick Norwitz, who is a medical student at Harvard Medical School and has a PhD and has I guess I would say a knack for stirring the pot and trying to cause a little controversy purposely to make a point. So with his experiment of adding Oreo cookies to dramatically lower his LDL and compare that to the lowering effect of high-dose rosuvastatin or Crestor, and saw how the Oreo cookies dramatically outperformed, I guess you could say, quote unquote, the statin for lowering his LDL cholesterol. Now, he openly admits this was meant to be controversial, it was meant to be sort of clickbaity in a way, but to emphasize a point and to hopefully create a an enthusiasm around wanting to learn more about this. So you as a clinician, as a researcher, as an advocate, when you see something like this, when you see this type of experiment, how do you think we as medicine should respond? And what have you seen as the response so far?
Well, I was this co-author on this, so full disclosure, it's mixed paper, and I was the second author. This is a case study experiment. It is a metabolic demonstration, and that's a term that Nick has used that I like. So, in the context of our previous conversation about lipid energy model, can you demonstrate physiologically that in a lean mass hyperresponder who's been well characterized and is being followed in a very intentional way, that data are resonant with and reinforce what you would expect from the lipid energy model? So that's where we start. It's a metabolic demonstration. And just to put a little bit of context around what you said, we're talking about a 71% drop in LDL cholesterol in 14 days. That's pretty dramatic. When you contrast that with a 30% drop with 20 milligrams of rosuvastatin over 6 weeks. So it tells me several things. Number one, again, our physiology adaptively changes much quicker than I would have previously thought. We're used to looking at lipid and lipoprotein changes in the context of a 5-year clinical trial. Okay, that's a long time. I got a baseline, I got 5-year data, or I'm seeing patients in the clinic and I see you every 3 months. Well, what happened between when I saw you and 3 months later? I have no idea because we didn't look. So this idea that we can actually move much quicker than that is, to me, that was a learning, and one that I've, over the last couple of years tried to understand better and better. Okay, so exactly what are the kinetics involved in this thing? And the other thing to take on board is that, and in Nick's case especially, you're talking about a very lean person. Data out there would say that there is a relationship between how lean you are and your likelihood for LDL elevation. The more lean, the lower the BMI, the greater the potential LDL elevation. That speaks indirectly to the idea that, yes, if you are very lean and you have depleted carbohydrate stores, you might be more adaptive in this way and show a higher LDL response than somebody who is not as lean, may have more stores, and may have a different magnitude of response. So again, these are pieces of the discussion that kind of continue to point in the same direction, but we're still learning, and that's fine.
Yeah.
So I look at this as a population that is not commonly encountered in my clinic, a population of individuals who have an interesting and previously not commonly seen response, right? And then in this somewhat uncommon response, can we do something that has a time frame which is much, much quicker than we previously thought? To put another piece of context around this, what's the fastest working drug we have for LDL lowering? It's a PCSK9 inhibitor. So if I give you a monoclonal antibody that takes out a protein called PCSK9, it's very good at its job. If I did a blood test for PCSK9 and gave you a shot of a monoclonal antibody PCSK9 inhibitor, you would have no detectable circulating PCSK9 in 4 hours. It's gone. And then in a matter of 7 days, you would have a steady state LDL reduction. So the fastest drug I have available to me right now mirrors the time frame that he accomplished by reintroducing carbohydrates. And a statin takes weeks to have its steady state effect. So I find that very intriguing.
Yeah. Yeah. But I think the problem is it's intriguing on sort of a higher level than what we've talked about before, about guideline care, about your 15-minute visits. And that's what I think why a lot of people are maybe dismissive of it, because they don't have the time. They don't have the curiosity to say, this is something I've never seen before. I want to learn more. It's a lot easier to say LDL ApoB is bad. We shouldn't be investigating this. We know this already. But yet this is the point. And this is sort of ties our whole discussion together about the personalized care, about learning more, about understanding a situation where we haven't really seen before in medicine, because ketogenic interventions are medical interventions. They are helping people put bipolar disorder, schizophrenia into remission. They're helping people put type 2 diabetes, Crohn's disease into remission, things that medicine has really struggled to do. So if LDL goes up, we do need to approach that differently. And now I'm just getting on my soapbox, but I think this sort of ties this discussion together. And that's where voices like yours, someone who has specialized in lipidology for 30 years, who does research, we're having your voice to say, wait, we do need to see this differently is so important, but yet unfortunately so rare. And especially within the world of lipidology, do you feel this has sort of put like a little bit of a target on your back or made you a little of an outcast to say this when it seems like the world of lipidology is just doubling down, that ApoB just has to be low, 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 low in everybody? What do you think about that?
So I would take a step back, and I like the way you phrase that, you know, we're struggling. We're struggling to do the right thing one patient at a time. And if that's kind of the way we're starting the conversation, I would offer these data in the following clinical context. You're on a ketogenic diet for a reason that has to do with your need to improve something. It could be a neurologic issue, other issues. The list is long. And you're having success. The thing that you're taking the ketogenic diet for is working. But my LDL is up. What do I do? Number one, who's the patient and what's going on? What's the status of your vessels? What risk-enhancing factors do you have? What's the bigger picture? Do I have something that we need to immediately have a conversation about? Oh, I did a coronary artery calcium score. It came back 400. You've got a fair amount of plaque, and a high LDL is going to feed that plaque. We got to have a conversation. Okay, so that's at least the first step. The second step is, if I want to lower the LDL, what are my options? One option is to introduce some amount of carbs back to blunt the LDL elevation while maintaining the benefits of ketosis. And this can be a staged, stepwise process. Hey, let's add 20 grams of carbs back and see what happens. How do you feel? Is it working? Still ketosis? Did the LDL come down? And you can rinse, repeat that as many times as you want to maintain both the benefit of ketosis and reduce carbs in a way that blunts some of the LDL response. I think that's a very reasonable takeaway from these data, is that there are non-statin ways to significantly affect the LDL elevation that keeps company with a ketogenic diet in lean individuals, right? So we don't have to just say, see, I told you that LDL was bad, take this pill. I think it's easy to say, but it's not always the most informative way to take care of an individual, right? So again, I'm pretty nuanced in the way I try to present things. I try to present things in a way that integrates all data rather than cherry pick data. And that's what the guidelines are asking us to do. Be more contemplative. Think more about your individual. Get their nuances and details in front of you so you can have that informed conversation. Yes, it's time consuming. Yes, it requires systems that may not be easily in place. You might need a precision health report in order to do something like that. But at the end of the equation, I'll just give you a quick example, right? 72-year-old lady came to see me. I introduced myself. I asked how I could help. She said, I'm here for you to tell me I don't need a statin. Well, who told you needed a statin? My doctor. Well, why did he say you need a statin? My LDL cholesterol is 210. First question I always ask my patients, when did that start? You're the first doctor to ask me that. She pulls out a binder. 5 years ago. 10 years ago, great. 5 years ago, not so good. She had hypothyroidism that hadn't been diagnosed. The reason for her high LDL was hypothyroidism. I said, okay, so here's the deal. We think LDL is bad as a function of how high for how long. It looks to me that your how long is very recent, 5 years. We'd like to know what's happening with your vessels. Coronary artery calcium score is 0.
At age 70,
72.
72.
And the guidelines say at your age, a 0 makes statins optional for at least the next 5 years. There we go, right? We ask additional questions. We sought to understand. From the extra understanding, we could put context around her number that she didn't need that.
Yeah.
All right. So this is the type of thing I think we owe our patients. We owe them the opportunity to have the totality of their information considered, and not just a single biomarker.
Right. What do you think your 20-year ago self would say if you were told you're going to be a co-author on a paper about lowering LDL 70% with Oreos, and you're going to see a study being done on people with LDLs of 300, 400? What would your 20-year ago self have said to that?
I would have thought it was crazy. And this is the challenge, right? When I started some of my research in lipoprotein analytics in the 90s with my longtime research partner, Jim Otvos, Jim and I started by saying, we're going to let the data teach us. And one of the greatest compliments I got at a conference I spoke at a few years ago was a guy came up to me afterwards and he said, I saw you 10 years ago and you're saying different things now. I said, isn't that great? And he looked at me strangely. I said, that means, we're letting the data teach us. Yeah. And that's the key is, you have to remain humble. You have to remain teachable and coachable. You have to let the data teach you. You have to believe we haven't arrived yet. We don't have all the answers yet. Individuals are individuals for a reason. We can't put everybody in a bucket and consider they're the same. These are just principles that have, been bedrock for me in my, journey as a clinician, as a researcher. And, we're not done yet. We still have a lot to learn. And the fact that we can, take on thorny issues, and people are going to be polarized by thorny issues. And I hear it all the time. It wasn't so long ago that, the whole debate was cholesterol doesn't matter. Right. And so there were people throwing stones on each side of that. Cholesterol is just a crazy overdone thing due to the pharmaceutical industries. And then there are other people like myself who would say cholesterol doesn't cause vascular disease. It's the particles that carry it. We're asking the wrong question to begin with. And now we're, tuning into a much better conversation of physiologically, who is our patient? What's going on for them, good and bad? How long has this potentially injurious thing been around? Does any imaging study tell me there's something for me to care about yet? And what's the reason why we're on the ketogenic diet in the first place? Oh, I had this problem and it's getting a lot better on it. Okay, so there's value in this. That doesn't mean that if I take you off the ketogenic diet, there's no downside. There could be. Right. So we're going to be trading one thing for another. And how strong are you in your convictions that getting off that diet and dropping the LDL is going to be a high likelihood of vascular benefit versus perhaps, the issue that they are seeking to impact with the ketogenic diet? In some cases, that's going to be an easier question to ask than others. And the last thing I would say is where we made a fundamental shift in the last several years of caring about risk factors earlier in life rather than later in life, which is critically important. Because if it's true that risk is a function of how bad for how long, why are we waiting for people to have their stent bypass or event in their 60s to care? We've waited way, way too long. Why should we just wait for ABIs to be less than 0.85 and have, symptomatic peripheral vascular disease to care? We've waited way too long. I hope we're getting into conversations at a much earlier age of, what does metabolic health look like? And if you're on a bad path, we don't have to stay on it. We can change. And we can change in fundamentally important but non-pharmacologic ways. It doesn't have to be a pill. As a matter of fact, in my practice, a pill is not the first step. I call medicines mops and brooms. They clean up what mess is made, or left over after I fix what I can. Yeah. Right? So medicines are important, but as the appropriate step, not the first step in all cases.
I really appreciate that perspective. And you really shed a very good light on this whole topic and a great curiosity and individualistic approach, which I think we definitely need more of. So thank you so much for joining me. And if people want to, learn more about you, where can you direct them to go?
Sure. Well, if they're interested in this integrated approach to understanding your risk for heart attack, diabetes, stroke, precisionhealthreports.com. Precision Health Reports is the website where you would learn more about the way that we integrate these things. We also have presence on X. I still call it Twitter. X sounds
Yeah,
odd
me
to
too.
me. Precision Health Reports as well. And then, Nick and I have this paper that's coming out. Dave and I work together. There are going to be opportunities for continued conversation with you and in other venues. So as people are, looking for good conversations, I would say, what we're doing now and similar types of conversations will continue to happen.
Very good. Thank you very much.
All right. Thank you.